Welcome, everyone, to another episode of From Print to Pod. We have with us Dr. Stephen Cohen. We're going to be discussing his article titled Healing Beyond the Blade, The Legacy of the Master Surgeon. Dr. Cohen is a seasoned surgeon, educator, and mentor who has spent more than 3 decades in the operating room, clinic, and classroom. So I am actually going to let him quickly introduce himself before we get right to the question. So, Dr. Cohen, welcome.
Thank you so much. Happy to be here. So, correct, it's been now year 31, college and medical school, UCLA, surgery training at Boston University, then a colorectal fellowship at the Cleveland Clinic, Florida, back in the 90s. And I've been teaching, training, educating medical student residents, first in the private sector for 23 years, currently at the Richmond VA Medical Center. Passing on the things that I learned over the last 3 decades.
Beautiful. And I don't know if I mentioned, but I did my undergrad at UCLA, so we do share that. Okay, let's get right into the question. So, first question is you describe experienced surgeons as offering not just knowledge, but judgment and wisdom. How do you believe these qualities can be effectively passed down to today's residents?
Yeah, and that's a great question, and I deal with that every day in almost every patient encounter, whether it's in the clinic or in the operating room. Is that good judgment comes from experience. Experience comes from bad judgment. As surgeons, we are going to have complications. It's not the complication that's the issue, is how do you deal with the complication? You have an angry patient, you have an angry family member, you've done everything right, everything you were trained to do, but it's how you deal with some of those things over time that really shapes the kind of physician or surgeon that you are. You only get that with experience.
You mentioned bridging the generational gap in surgical training. What specific challenges do you see in the current training model, and how can veteran surgeons like yourself help address them?
Yeah, and that's a great question. The surgery in the last 30 years has changed dramatically. When I was a third year surgery resident in 1990, one of my colleagues was standing up at the M&M conference and presenting the first laparoscopic gallbladder that was done in the state of Georgia. The senior surgeon at the end of the presentation stood up and said, "That is BS. That is malpractice. We should never do that." Fast forward, it is now standard of care. I think I trained at a great time. We probably all say that, but back in the 80s and the 90s, all surgery was open. We did not rely on CAT scans to make a clinical diagnosis. We operated on the patient. Was that the best ever? That's all we knew, right? Fast forward to today. Everybody that sneezes gets a CAT scan. I cannot tell you the number of times when a young learner surgeon, even at the PGY3 and above level, when they present to me a case, they leave out the physical exam. What are you talking about? How could you not make a decision? Because the teaching, the training, it's a little bit different. They don't have to open the book anymore. They watch things on YouTube. They watch things on podcasts, which is okay. There's some very good things out there, obviously. They're not like me. I carried the Washington Manual in my pocket. That was my reference day in and day out because we didn't have any of that stuff. So the training, the teaching is a little bit different. The way we do surgery is different. What I received at the end of 7 years of surgery training is not the same as that these kids get, because the way we do surgery is different. And that's a challenge to teach them about some of the things that to me were routine 30 years ago that are not so routine now.
That makes sense. We're definitely going through an evolution in so many different ways. Modern healthcare has become increasingly complex and bureaucratic. How has your own approach to maintaining patient-centered care evolved over your career? And also, how do you teach that to younger surgeons?
Yeah, that's a great question. I get asked that question a lot by the residents, especially the ones going into a private practice setting. If most most of these kids now, and I call them kids there because of my kids' age, but most of these kids now, when they join a practice out of residency or fellowship, they're joining either an academic. Most of them go into an academic, whether it's trauma surgery or vascular surgery or surgical oncology. Very few go into like straight general surgery. But the other thing is, most physicians nowadays are employed by hospitals or employed by third parties. That was not the norm 30 years ago. There was very few of us, and I went into private practice. I was my own boss. So there's a lot of challenges, there's a lot of differences. You don't have a lot of say. They look at metrics. How many patients are you seeing? What's your RVUs? That is noise. You have to, and it's hard, but you've got to eliminate the noise and remember that that patient, whether it's a man or a woman, could be your mother or father sitting across the room. And, if and when you make the decision for surgery, you have to look at it through the lens of, is the surgery indicated? And would I want this to be offered to my family member? And if you look at it from that aspect and stop counting RVUs, because that's what the bureaucrats are going to do to you, then you will have a successful career.
You know that I have a lot to say about that, but this is your 15-minute podcast episode. So, professional resilience is a major theme in your article. What are some key lessons or habits that helped you avoid burnout across 3 decades in surgery?
Yeah, it's what my mother says, is that a busy person is a happy person. And I tell this to the residents all the time. I get you for a short period of time to teach you to become a safe surgeon. That is it. I can teach you the basics. I can teach you disease process, but you are going to be learned to become a doctor in practice. You are going to be faced with situations that I can't duplicate real time. The angry patient, the angry family member, the patient that had no risk factors for heart disease on day 3 died of a massive heart attack at age 50. Deal with that, right? You got to put on your big boy and big girl pants because I can't get you through all those things. So, it's being compassionate, it's being empathetic, it's putting yourself in the patient's situation. How do you want your mother or father treated? And I think those are important things that you need to learn as you go along. I give the young learners a lot of autonomy to deal with these situations, to try to help them so it's not oh no, I never thought about this thing, which happens to all of us when we enter practice.
So we spoke about this topic a bit already in this conversation, but it's that important that the culture of surgery is clearly changing. What traditions do you think should be preserved, and what needs to continue evolving for the next generation of surgeons?
Yeah, the physical exam, which seems to be lacking in a lot of things that I either get presented a patient or review a chart on a medical malpractice issue. It's the electronic, the pick on the electronic medical record. The only good thing about the electronic medical record, nobody complains about Dr. Cohen's handwriting. Other than that, there is so much copy and paste because, physicians are resilient. We will find a workaround for all the nonsense that you put us through, and that's one of them. The copy and paste drives me crazy. You can't have a patient who goes with a change in clinical status, white count, lactic acidosis, stool coming out the incision, and the physical exam being the same every day. Okay. It's obvious when you do that. So, but again, it's information overload. We are inundated, the residents are inundated with, documenting and doing it correctly. So that's got to stop. You got to do the best you can to document appropriately, pay attention to the physical exam, and put your differential in what you're thinking, right? Because again, the old adage that if you don't document, it didn't happen still is true, especially in a court of law. Put the differential in. What are you thinking? Who did you talk to? Get the family members involved if there are. Those things have got to continue with or without the electronic medical record.
It's admittedly very hard in a field that's already challenging. And now you've got those added challenges of things like EHR and prior authorizations and all of these almost newer concepts that weren't traditionally in place. So you speak about the gap between academic theory and real world practice. Can you share a specific example from your career that highlights how clinical reality taught a lesson no textbook could?
Oh boy, I have a lot, but the one that the light bulb went on was about the first 3 months in practice. Here I am. I've been in training for 7 years, thought I knew everything, of course, right? And a patient comes into my office with diverticulitis. Classic signs and symptoms. She was pretty tender on exam. She was a little tachycardic, I could tell by my physical exam. Told her she needed to be admitted. Right. I admit her to the hospital. I do the CAT scan. I put her on antibiotics. The next day, as I walk onto the ward, her primary care doctor is standing outside her room. I had never met him before. I was new. I go to walk to the room. He says, I introduce myself. He says, let me talk to you over here. He says to me, quote, and he became my friend afterwards, but he said to me, quote, if you ever admit a patient of mine again without telling me, I will never send you a case again. And he stormed away. And I'm thinking to myself, I thought I did the right thing. Patient comes through the problem, but private practice is not an academic world, right? As a resident, if I called the medical doctor, my colleague resident, they would argue with me about who's admitting. They don't want to do the work. But I had to realize in private practice that doctor gets paid to admit the hospital, admit the patient to the hospital. I was taking money out of his pocket. So it's a different thinking in private practice than a resident run situation.
Before I go on to the next and final question, I am going to interject and just say that Dr. Cohen is going to be a speaker in our lineup of the Entrepreneurship and Networking Conference. His lecture is going to be titled Prescribing Prosperity, Diversifying Income for a Resilient Medical Career. Can you tell us just a quick bit about what you plan to teach?
Yeah, and it's what I teach every day is that, a busy person is a happy person. There's a lot of things that physicians can do that are not clinical at the bedside. So, multiple streams of income is one of the ways that I've prevented burnout myself, right? I mean, yes, I like doing a lot of rectal exams. Yes, I like doing a lot of surgery. However, in the past 3 decades, I've worked with industry, teaching, training, educating drug reps about what surgeons need, what they like, what they utilize in the OR. I've done utilization and peer reviews for Medicare, for Medicaid, for other third-party insurances. I have a very large medical legal practice, teaching, training, educating attorneys, juries, those types of things. So there are a lot of things that you can do that's not what you are trained to do that is very helpful for all involved. And that's one of the main things that really helps burnout for sure.
So you talk about rediscovering purpose through teaching, which we just spoke about. How has becoming a mentor changed your relationship with surgery and with medicine overall?
Well, it's giving back. I mean, it's, one of the reasons that I chose colorectal as a field was my mentor. I rotated at Leahy Clinic as a resident, which is one of the best colorectal hospitals in the country, I might add. And I like those physicians. They were a wealth of knowledge. We did great cases. I wanted to be like them. My goal as a mentor, as an educator, is at least one resident a year. I want them to like colorectal surgery so much that they choose that as a specialty. And I'm happy to say, since 2017, we're now up to 8 residents that have decided to go into colorectal surgery. So I'm proud of that. I like that because if they want to be like me, maybe they don't want to be everything like me. That's fine, but that's giving back to what I got 30 plus years ago.
That's beautiful. You're setting up goal posts there. And speaking of those, you are also speaking to our audience at the Finances Investing in Real Estate conference that's being held also online. All of our conferences are online. You're going to specifically be teaching the lecture Finances for Young Physicians, where you're going to be teaching budgeting, managing debt, investing, and planning for retirement early to build wealth and achieve financial security as a young physician. I'm all for that. Can you just quickly touch on why it's so important to think about money when you're young, and why is money not a dirty word?
Yeah, money is definitely not a dirty word. I mean, we are in a business. You have a practice that is a high income. Everybody knows that. That's fine. And the problem is, by the time you start your career, you are way behind the eight ball from all of your friends. I mean, I started in practice at age 31. A lot of people, it's even back then, a lot of people are older now. All of my friends from high school were already had their retirement savings, already had all the things that I didn't have. So you have a shorter lifespan of saving. Obviously, we'll get into compounding interest. The earlier you start, the better. And you can do it with the right mindset. And I've made all the mistakes, okay? Because when you start, you want to immediately go out of the gate when you finish your residency and your salary quadruples, which it will. In your mind, it's exactly, you're going to say what I said. I worked hard, I deserve it. I worked hard, I deserve it. Yes, you worked hard. Yes, you deserve it. Wait, because in 30 years, if you're smart and live like a resident for the first 5 years, you will be, when you're my age, you will be financially secure. You'll have no debt and you'll be doing this for fun. And that's what you want at the end of the day.
Oh, I am so excited just listening to this and talking about this. I could not agree with you more. We are looking so forward to hearing from you, not only at our conferences, but also in our magazine. Everybody loves what you have to say. So thank you, Dr. Cohen, for joining us, and looking forward to the next one.
Thank you so much.